Hi everyone, my name is Jack G, and I'm one of the Megamind 2023 winners. Today, it's my true honor to be here, not as a contestant this time, but as your host. I am very thankful to Megamind platform as it offered me unimaginable opportunities and stages to grow and shine. I feel also fortunate to be guided by the inspiring mentors and also be surrounded by a group of like-minded clinicians all around the world. To all the participants, it is definitely not easy to get to this stage as you have already prepared so much and gone so far. You have achieved so much today and deserve everyone's top respect. Ladies and gentlemen, please give our contestants a big round of applause and encouragement. Now, allow me to introduce the rules of the competition today. Each participant will deliver a 15-minute presentation showcasing an implant-focused case and their approach from diagnosis and treatment planning to clinical execution and follow-ups. And here's how the judging criteria will work today. Presentations will be evaluated based on purpose and clarity, clinical impact and novelty, case workup and documentation, ethics, and evidence-based rationale, as well as structure, visual quality, communication, and audience engagement. Be mindful that each participant has 15 minutes to do your presentation, and how well you manage the time will also be part of the evaluation. Now, it is my privilege to introduce our distinguished judges. Please welcome Professor Guhan Durgin from Marmara University and Professor Kornel Krasny from Medical University of Warsaw. Thank you for joining us and for providing fair and professional evaluations today. And we are also very proud to welcome our contestants for this Continental Round League in Asia. Dr. Jackie Yu from Australia, Dr. Aksornsan Pongsettakul from Thailand, Dr. Kannika Bureekanchan from Thailand, Dr. Ongart Puttipisitchet from Thailand, Dr. Esmond Siagian from Indonesia, and Dr. Taishi Nago from Japan. One more highlight for today. This is a live global event and a historic moment for Megamind. For the very first time in the competition's history, we are using a real-time AI interpretation system to create a truly global stage where great implant clinicians can present their clinical cases and be worldwide listened to without any language barriers. Simply scan the QR code on the screen. Select your preferred language and enjoy every presentation in real time. If you want to support your favorite speaker, please cast your vote during or after the competition on the official website www.globalmegamind.com. Alright, welcome once again to Megamind 2026 Asia Continental Round. Let's kick off this magical event.
Hi everyone, my name is Jackie and I'm a periodontist based in Brisbane, Australia. I would like to thank the Megagen team for this opportunity to present today. I also like to thank my mentors and colleagues who supported me and guided my journey into becoming a dentist and periodontist. The topic of my presentation today is vertical ridge augmentation, challenging the possibilities of guided bone regeneration through scientific evidence. Guided regeneration has fundamentally transformed implant dentistry by improving the success rate of implants place in deficient ridges. And we'll have to thank the pioneering researchers and clinicians all around the world who investigated and brought regeneration into clinical dentistry. Being a periodontist, I am certainly a major beneficiary of these breakthroughs. As many of us already know, guided regeneration in the context of dentistry began with experimental studies on periodontal wound healing. These incredibly inquisitive researchers were able to demonstrate that when a barrier membrane was used to prevent gingival cells from reaching the root surface, it gave an opportunity for periodontal ligament cells to repopulate the defect, and new connective tissue attachment can then form on the root surface. With early encouraging results from guided regeneration in the field of periodontology, researchers and clinicians became curious on whether the same concept will apply in GBR in dentistry. This led to a study that investigated GBR, and nowadays GBR is so routinely used in approximately half of the implant cases that we do. It is a validated technique to reconstruct deficient ridges and to restore function and aesthetics for our patients. Although the impossible was shown to be possible, there were certainly challenges that clinicians had to face as they embark on the journey of regeneration. Two of the biggest challenges that we faced in any major bone augmentation is one, the collapse of membrane into the defect, which in turn reduces the volume of bone gain. And secondly, the dehiscence of soft tissue, which can then lead to membrane exposure and infection. These challenges are faced even by the experienced experts in the field. It was clear that we had to tackle these challenges. For example, we selectively use different types of bone graft materials to prevent the collapse of membrane and to maintain space so that osteogenic cells can repopulate the defect and form new bone. Our flap management techniques have also continuously to evolve to allow for better closure of soft tissue. And different membranes of different characteristics have also been explored. And as we gain more knowledge in tissue biology, I believe we will start to use things like scaffold and biologics more and more in clinical settings. One of the most challenging types of defect to reconstruct is vertical ridge deficiency. So I'm going to share my journey and learnings on guided bone regeneration through a vertical ridge augmentation case today. My patient, Jen, is a 65-year-old patient who's having difficulty eating because of significant number of missing teeth on the right-hand side. She has had multiple lower dentures made in the past 3 decades. However, they were poorly tolerated, and she continues to experience difficulty with mastication. Before we dive into the journey of ridge augmentation, I would like to first highlight what happens when we extract a tooth. Following extraction, you lose about 50% of the horizontal width within the first 12 months. And most of that already happened within the first 3 to 6 months. So that process happens quite quickly. A more recent systematic review in 2020 showed that at a molar site, horizontal ridge resorption amounts to around 3.5 millimeters, and vertical ridge resorption occurs to about 1.5 millimeters. You may think that at a molar site, the average socket width can be quite wide, around 10 to 12 millimeters. So surely, even with that amount of resorption, you will still have enough bone for implant placement, right? So why do we see very significantly resorbed ridges in clinical settings that left us with very diminished bone? Well, at the edentulous site, the residue ridge can often undergo progressive but slower resorption over time, beyond the initial ridge modeling. Though this process is not completely understood, the progressive resorption is likely related to age, poorly fitting dentures, or even pressure on the alveolar mucosa. And the end result is a flatter mandible with a significant vertical deficiency. This is highlighted quite well by a classic study published by Corwood and Howell in 1988. Let's examine our case again. Long-standing history of tooth loss, as well as poorly fitting dentures, has contributed to very significant vertical and horizontal ridge deficiency, as you can see in the photos. This also resulted in very shallow vestibular depth. Hence, this is a more challenging case that requires major bone reconstruction. How do we improve the predictability of GBR? The past principle proposed by Professor Honglei Wang provided a very useful framework to help us tackle the challenges of bone regeneration. The key 4 pillars are primary closure, angiogenesis, allowing revascularization into the augmented bone, space maintenance, creating space so that osteogenic cells can repopulate the defects, and stability to allow for more predictable wound healing. These are principles that should be followed regardless of the types of ridge defect that we are trying to tackle. For example, in the horizontal augmentation case above, cortical perforation is performed to improve the vascularization of the graft. Bone grafts were then applied and secured using collagen membrane and bone tacks. This is for the purpose of space maintenance and stability of the wound. And finally, the flap was advanced so that tension-free soft tissue closure can be achieved. The same requirements are also necessary for successful vertical ridge augmentations, but it becomes much more challenging because there's a lack of osseous wall to help us stabilize and contain the bone grafts. To overcome this, a rigid membrane, for example, a titanium reinforced PTFE membrane will need to be used. Vascularization of the graft is also much more challenging as the cells will have to travel a greater distance through the graft. And tension-free soft tissue closure is much more difficult to achieve. So coming back to the case that we're presenting today, CBCT clearly highlights the extent of vertical ridge deficiency. At 4.5 and 4.6 site, the residue bone height to the inferior alveolar nerve is approximately 6.5 millimeters. So as a result, even with a very short 6 millimeter implant, it's not really a viable option in this scenario. And therefore, vertical ridge augmentation is required to enable the placement of implants at these sites. Here are the steps during vertical bone augmentations. In order to achieve tension-free primary closure, on the lingual side, the myloid hyomuscles were carefully and bluntly dissected from the lingual flap. On the buccal side, the mental foramen was carefully identified, and later on, periosteoreleasing incision was done, carefully avoiding the mental nerve area. A 10-pin screw was placed to help maintain the space and wound stability, given the uncontained nature of the defect. And at this stage, cortical perforation was performed on the buccal side to improve angiogenesis and enhance graft revascularization. We used autogenous bone chips harvested from the patient's mandibular ramus and combined with bovine-derived xenograft, aiming for approximately 50-50 mixture. This combination leverages the osteogenic potential of the autogenous bone, while also benefiting from the long-term volume stability of the xenograft. A titanium reinforced DPTFE membrane was then adapted and securely fixed to prevent any micromotions and to help us maintain the space. A resorbable membrane was used to cover the PTFE membrane, and a combination of horizontal mattress sutures and simple interrupter sutures were used to achieve primary closure. This was reviewed at 2 weeks' time. Primary soft tissue closure was maintained, and the photo taken at 6 months post-surgery showed healthy mucosa without signs of infection. An updated CBCT scan was then taken, which confirmed that vertical ridge augmentation was maintained and bone graft appears to be consolidated. By comparing CBCT scan that we had before the surgery, it was estimated we had approximately 4 to 6 millimeter of vertical bone gain. So now there is sufficient ridge height for us to plan for implant placement with standard lengths, in this case, 8 millimeters. We then constructed a surgical guide based on our diagnostic wax-up to facilitate the implant in a prosthetically desirable position. These were photos taken at re-entry surgery at 7 months. Crestal incision was made alongside a edentulous ridge. The underlying membrane is exposed and removed, and here's a photo of the augmented bone. 2 8 millimeter long implants were then placed at the 4.5 and 4.6 sites according to our planned position. And while we had sufficient bone volume horizontally and vertically, a superficial layer of soft immature tissue was felt. And this is likely that the augmented bone was still in the process of remodeling and maturation. So a thin layer bone graft was then placed over the implants in order to prevent graft resorption on the superficial layer. And this is in line with Professor Istvan Erbert's protocol, when onlay grafting approach may be employed in such situation to reinforce the ridge volume and to prevent graft resorption. So now that we had addressed the hard tissue deficit, attention turns to peri-implant soft tissue. As demonstrated in the previous photos, the buccal mucosa has been extensively released on 2 occasions. And this has worsened our soft tissue deficiency, which led to a lack of keratinized tissues, reduced attached mucosa, and a shallow vestibular depth. The importance of peri-implant soft tissue in maintaining long-term implant health is increasingly recognized, but there remains debate on whether there's an optimal timing of soft tissue augmentation. In this case, my opinion is that the augmentation of the soft tissue is beneficial in long-term plaque control and maintenance of peri-implant health. Here's what we did for soft tissue augmentation. A partial thickness flap, apically repositioned flap was raised. All loose, movable, loose connective tissues were carefully removed from the recipient bed to create a stable, non-mobile recipient bed for our free gingival graft. And free gingival graft was harvested from the palate and secured using sutures. So here's a video showing that the free gingival graft remained relatively stable despite the stretching of the underlying mucosa. 8 weeks following free gingival graft, a second stage surgery was then performed to uncover the implants. These were photos taken following the final insertion of the implant crowns at 4.5 and 4.6 sites. And here's a comparison photos of before ridge augmentation on the left-hand side and after ridge augmentation and implant replacement of the missing teeth. This is a periradial graft taken at 12 months post-insertion. So vertical GBR can be successfully used and address ridge deficiency, but we have to understand that it is a very technically demanding procedure, and systematic review by Urban 2019 showed that the mean vertical bone gain using GBR technique is around 4.2 millimeters. But there was also a complication rate of 12%. It also should be noted, however, in the studies included in the systematic review, it mostly consists of case series, and there's a high degree of variability between different studies. And this stresses the importance of very careful and strict case selection and execution of appropriate surgical techniques. So in closing, I want to express my gratitude to the researchers and pioneering clinicians whose dedication has transformed what once seemed impossible and unpredictable into something that's increasingly achievable. And this is achieved through the exchange of ideas within our professional community. GBR is a technique-sensitive procedure, increasingly so with larger uncontained defects. So many patient-level and site-level factors can affect the outcome of GBR. So therefore, as clinicians, we have the responsibility of continuing to improve our understanding of biological healing, our case selections, and surgical techniques to help optimize outcomes for our patients. Thank you for your attention.
Recording stopped.
Okay, thank you for your presentation, Dr. Yu. So the judges, any comments? Professor Guan, I cannot hear you.
It's okay?
Yes.
Okay.
Now,
Dr. Yu, thank you very much for your excellent presentation. I just want to ask, the follow-up is almost 1 year, right?
Yeah.
Okay. And you just put one, I think, X-ray. I see only one X-ray. I mean, periapical.
Yeah. Yes. So unfortunately,
it's better to see, the beginning and the finals, and comparing together. It should be the case is perfect. No doubt about it. But it is better to put some steps, radiographic steps, at least peripicals could be better to identify what's going on,
Yeah,
But good.
absolutely. Yeah, thank you for the feedback.
Thank you very much. Thank you very much for your this excellent presentation and documentation.
Thank you, Professor.
And I wish you luck for this competition also. You do very good.
Thank you.
Thank you very much.
How about Professor Krasny?
Thank you very much, Dr. Jaik. It was very interesting. I think it was very difficult case because the augmentation, vertical augmentation, every time is difficult. You have a very nice effect and nice present. Thank you very much. Congratulations.
Thank you, Professor. Thank you for.
Good afternoon, honor committee and all attendants. Let me introduce myself. My name is Dr. Aksornsan Pongsettakul. I am oral implant surgeon. Today, I would like to share my case in a title of computer-guided implant surgery in atrophic anterior maxilla using a cantilever restoration with simultaneous guided bone regeneration and soft tissue graft augmentation. So let's go to my case. a healthy female, 53 years old, with no relevant of medical history, no drug allergies, non-smoking status. She presented to my clinic with the chief complaint that she lost her front teeth approximately for 10 years. And since that time, she began to wearing a removable dentures. And right now, her own dentures had poor aesthetic and lack of retentions. And she now wants to replace it with the fixed restoration. And after taking the examinations, it's present she had the edentulous area in the four maxillary teeth of maxilla with flattening of the alveolar ridge. And underneath the denture, it has significant inflammation at the palatal tissues, which may suggest that it has a denture stomatitis. And because of she need to do the implant, so I refer her to do the CBCT scan. And the CBCT results as shown in the video, it revealed that she had a moderate to severe horizontal bone resorption with mild vertical bone loss. And it's confirmed that her alveolar ridge had a significant horizontal loss because it's present that its transformation from the natural convex shape into a straight line. So in this situation, the augmentation is unavoidable, period, to place the implant. So I discussed the plan with her and the need to do the augmentation. And during our conversation, she told me about her anxiety about the surgery. That is why she wearing denture for so long. And she insists to do the implant with the fewer surgical session as much as possible. And this is challenge for me too, because it's a hard case, but I assure her that I will try my best to do a research and we'll come back with the option that we could make the decision together. So finally, I have made the list of options, which based on the aesthetic consideration, biomechanical factor, cost, and surgical complexity to assist her to making a decision. And I made the three options. Beginning with the first option is a 4 individual implant for each teeth. This option may be good for long-term maintenance, but in this option, it's most expensive cost and its lack of guarantee the aesthetic. It's because of the achieving ideally for implant placement, which placed near together is hardest point, and it's also the hardest option to do the graft augmentation in this option. And the second option is placing the implant at the lateral incisor and do the bridge. In this option, actually is ideally option in this situation for the prosthetic aspect due to it have a superior mechanical resistance and it's more easily to clean the aesthetic with papilla with the pontic in this situation. But for the surgical aspect, the area of in the lateral side, especially in this patient, she had very thin bone, and her bone thickness is only 1 to 2 millimeter. So a stage approach using the bone block graft or non-resorbable membrane is needed for her case to achieve 5 to 6 millimeter to gain the thickness for proper implant placement. So this option may have a surgical complexity comparable to the first option. So let's move to the third option. This option, we will focus on this option. In this option, specifically on this case, it had an advantage in surgical aspect because the central bone in this case, particularly in the central incisor, it has approximately bone thickness about 2 to 5 millimeter. And these allow surgeon can simultaneous implant placement with the guided bone regenerations, which less complex than the first two options. But to placing the implant at the central incisor with the lateral cantilever is an uncommon first-line option. And the primary concern is the risk of the tissue flattening between two of the central incisor, which may cause an aesthetic risk in the future. However, the accurate implant placement could reduce the risk for this such a case. And two main points is, first, the distance between inter-implant platform should be positioned more than 3 millimeters. And the second, the thickness of the buccal bone, which gain from the guided bone regeneration or the remain bone thickness, should be exceed than 2 millimeters to prevent long-term peri-implant tissue recession. And from biomechanical aspect, previous research indicates that the use of cantilever implant in the anterior regions does not affect the implant survival rate. And to place the implant in the central with the lateral cantilever at the lateral tooth is had benefit due to the shearing force and mainly impact on the central incisor, and the lateral force always affect to canine or posterior teeth that leaving the lateral incisor out of occlusions. However, this approach not suitable for all cases. It has the contraindication in the case with deep bite, anterior guidance have parafunctional habit. Why the implant that should be used is the implant with regular size with standard range to avoid the future mechanical complication. So it is possible and that can make for this option, with the key factor is the effective case selections. For this case, she have no deep bite, no parafunctional habit, and she have the canine guidance. So her case is quite suitable for this option. And second is the 3D positioning, which can help by using the reliable computer-guided surgery system. And use the standard implant with good surgical procedure and hygiene maintenance will promote the long-term stability and prevent the mechanic problem in the future. So finally, she decided to do the implant with this option. And all plan was set, beginning with the first step, that is the planning the implant position with the Atrophic program computer-guided system, that the precise implant was planned in tooth number 11 and 21. Once the guide ready, the first surgery was scheduled. After local anesthesia was administered, a full thickness flap was raised, expose the thin bone underneath. As you can see, she has very thin bone. So this is why the reliable surgical guide is so important to use, because in this case, the misdirections will change the whole plan. In this case, the position of the implant were placed perfectly with the plan of the computer guide, and due to the severe resorption of the bone thickness in the maxilla, its present dehiscent and horizontal defect occur along of the mesial and palatal sides of the implant according to the computer-guided plan. And the guided bone regeneration plan were done first by decorticate the maxilla and harvest the autogenous bone particle. In this case, I used safe scraper and harvest the particle from the nearby area to mix with the xenogenic graft particle in 50-50 portion. And after mixed the graft particle, the graft was placed at the surgical implant area and covered with the resorbable membrane, which stabilized by 4 titanium tag sutures. And I used suture 50 sling tightly 1 second to prevent the movements of the graft. And the flap was released and repositioned without tension with 50 suture and 30 PGA suture. 2 weeks later, the patient was appointed to remove the suture. After remove the sutures, there is mild inflammation in some area, but no dehiscence or dislodge of the graft was detected. And at 3-month follow-up after surgery, the healing was uneventfully. The surgical area still intact with no inflammation. Same as the 3 months. At 6 months after surgery, the surgical site still uneventfully healing. And at 6 months in this stage, I plan to do the second stage surgery with soft tissue graft and provisional crown restoration. And the horizontal thickness, when compared with the pre-operation, it increased, but some areas still have not reached the optimal thickness. So in that some area, I will use the soft tissue graft to gain the appropriate volume. After inject the local anesthesia, the full thickness fab will raise, expose the graft augmentation site. And as you can see in the slide, the bone graft heals really nice with the implant. When compared with the pre-op surgery, the augmented bone cover all directions of the implant surface, and the buccal bone gain show approximately over 2 millimeters when compared with the beginning. We confirm once again with the CBCT compared with the pre-operative. As you can see, all of the implant surface have covered by the bone, especially at the buccal bone site. As you can see that buccal bone gain at the buccal aspect more than 2 millimeters along the implant. And the cover screw was replaced by the healing abutment. And soft tissue graft was utilized to augment the site that lacked adequate thickness. And in this case, I used dense collagen matrix to enhance the volume. And after graft was seated at the required position, the suture were placed. During this time, I placed the healing abutment, waiting for the fabricate temporary abutment for the dental lab. 2 weeks later, patient returned for suture removal and to place the temporary crown abutment. And 2 months after placing the temporary crown abutment, patients was appointed for taking the final impression. After remove the temporary crown, as you can see, the soft tissue, the interdental papilla between two central implant was very nice, and the thickness of augmentations area show satisfying result. When compare the result from pre-operation, as you can see, the dramatic change of the thickness, horizontal thickness contour. The flat resorption lid transformed to convex shape once again as we need. And after final impression was taken, 2 weeks later, patients were appointed to get the final crown. And 2 zirconial crown of central incisor with lateral cantilever was placed perfectly on the day of insertion. The crown and cantilever and soft tissue are harmonized and stable. And 1 year later, she come back to follow up. And the crown restorations and soft tissue around the implant and the marginal bone is still stable. When comparing the periodical X-ray taken immediately post-operation and those to 1 year post-insertion, the stability of the marginal bone surrounding both implants remains stable, no resorptions of the bone. And it is close to the end of presentation, but I need to show the important things about the hygiene maintenance, which also important. In the patient, she demonstrated excellent cooperation while using dental floss to clean underneath the cantilever crown. And after 1 year, she presented with no bleeding around the implant and no debris was found underneath the cantilever. And this is the transformation from the poor hygiene danger, severe resorption, horizontal alveolar ridge into the fixed restoration. And she very satisfied with the results. And at this moment, she can smile with a happy face and confidence once again since she lost all her teeth for a long time. And this brings me to have a joy and happiness as well. So finally, I would end up this presentation with the conclusion that the success of the implant therapy does not rely solely on the final clinical outcome. The true success is lie on achieving a balance between scientific principle, clinical feasibility, and patient satisfaction. And with effective communication, will transform a complex of clinical situation into outcomes that are both functional and satisfactory for the patients. So thank you for your attention.
Recording stopped.
Okay, thank you for your presentation. So our judges, any comments? Professor Kuan, yes.
I open it, yeah.
I am Professor Pongsettakul Siagian. I am the Dean of the Faculty of Dentistry, 𝐀𝐒𝐈𝐀 University, Bangkok, Thailand. My specialty is oral and maxillofacial surgery, and my passion is education, research, and inspiring the next generation of dental leaders. To me, MINEC is not just a competition. It is a place where ideas grow and innovation thrives. I join because I believe in supporting young professionals who dare to think beyond the usual. When I was a student, we didn't have something like MINEC. Global platforms were rare, and opportunities to share ideas internationally were limited. That's why I value this so much. It offers the kind of chance I wish I had. For the next generation, MINEC is a gateway to connect with peers, to learn from mentors, and to share their vision with the world. It is a chance to grow, share, and truly make an impact. The real strength of MINEC is that it combines competition with collaboration. It's not about the winning. It is about learning, sharing, and building a community of innovators. I am looking for finalists who show skill, creativity, and a sense of responsibility. Ideas that are not only innovative, but also have the power to help people in real life. Believe in your ideas, stay curious, be bold, and remember the ultimate goal is to make a real difference in patient care and in our profession. Unlock your potential, test your mind, make a mind.
My name is Emilio Arguello. I am a periodontist. I'm originally from Mexico City. I finished my residency at Tufts University. I spent about 10 years of my life doing research, intense research, so I spent a lot of time studying that bacteria. And when I finished my program, I got invited to become part of the faculty at Harvard University. Now it's almost 20 years since I've been teaching there. In the early stages of my career, I joined the corporate industry, which is one of the largest DSOs in the United States today. Soon after that, I moved to Denver, Colorado, and that's where I practice today. And I joined a private practice. My time had been divided ever since between the corporate world, the academic world, and the private practice world.
Welcome to the Megamind 2026, Season 4, The Road to Toronto.
Megamind is a very good project, and I'm honored to be invited as part of that team because that gives the clinicians, especially the younger clinicians, the ability to foster an unbiased approach and knowledge, and not to become necessarily attached to a product or a system. And also another thing that I praise a lot for the project of Megamind is that they have paid a special attention to the people that judge are not necessarily affiliated 100% to a company and freely judge the cases that are coming through without that attachment to the industry. What am I looking for in that competitive environment? The most important thing is how were you able to serve your patient in the best possible way? Your train of thought help that person's life and improve that person's life. It's also important to think outside the box. If you are able to deliver the correct treatment to your patient, along with an environment that you were able to come around the problem by the open-mindedness of thinking of a potential solution, that makes the case even more interesting.
It's okay. My name is Dr. Beatrice Lang. I'm a practicing prosthodontist.
All right, so Maureen, how's the gum on the, it's healed up, right?
I've been in private practice since 2005. My journey starts with going to dental school here at the University of Toronto. When I graduated, I realized that I was not comfortable practicing yet. So I moved to the States and I did a year of hospital residency at Boston Medical. The 3 years when I was in prosthodontics studying, that's when I realized that what I learned in dental school was not adequate. It was just a lot, there were a lot of missing links. I've always wanted to be able to help people to connect those missing links that were always there. So I got the position to teach back at the same dental school that I went to. So now I've been teaching for the last 6-7 years.
Megamind is a global stage for aspiring dentists to compete for a chance to become the next generation of leaders in implant education.
Megamind Global Competition as an opportunity to improve on my public speaking skills. There was no age limit. At this point in my career, why am I doing it, right? Yeah, to me, it's every opportunity is an opportunity to learn from, whether it's good or bad. Why not just try it? What's the worst that can happen? You don't win. You walk out with new experiences, meeting new people, and I think there's always something good that will come out of this experience. part of me is showing my sons that I'm still learning. I'm not perfect. I'm not afraid to try new things, and that I might lose, and that's fine. I like to do what I tell them to do.
Was lost and disappeared. What food you ate last night, how hard you bite the bone, remembering what I've told you.
My name is Dr. Ongart Puttipisitchet from Bangkok, Thailand. I have the experience as a dentist for more than 15 years, and my first dental implant experience started in 2010. At first, since a child, I don't like to be the dentist. I like singing, I like to be the artist. But because my family have a private hospital business, so I asked myself, why the good artist cannot be like an engineering created tooth in the dental field? At last, it's become the good combination for me. I like to go to church. We know that in the Bible, Jesus healed many peoples. I like to follow him. I can give the treatment as a healing for my patient as well, to be as a good Christian and good dentist. I find the Megamind last year, and I want to develop my presentation skill. Reaching the final round of the Megamind feel incredibly rewarding. Based on my first experience, I was able to reflect, grow, and come back stronger and better for this second opportunity.
Discomfort, pain, broken apart. Did you listen how to remove the way to save?
I think why I don't use the music as a part or the media to transfer this message of the dental implant to my audience. So that's why many people in Thailand know me as the singing dentist. This is my second time for the Megamind project. I will do my best for this time. And I looking forward to see everyone in Toronto 2026.
My name is Kannika Bureekanchan. You can call me Dr. Joyce. Since childhood, I have a dream of becoming a dentist because my mother bring me to hospital and I saw the dentist is so kind. I want to be like her. I graduated as a dentist in 2016 and subsequently worked at a government hospital for 2 years. After 4 years of performing dental implants, I graduated last year with a specialization in oral surgery and implantology. I attend the seminar and symposium in every year for treating to my patient because I want to help my patient in even better. Currently, I am working at Tung Song Hospital in Nakhon Si Thammarat province and at a private clinic in Hat Yai district. I believe that a professional dentist is one who combines both scientific knowledge and artistic skill to treat each patient uniquely. It's not only about having excellent treatment skills, but also about showing empathy and learning new techniques and knowledge to achieve the best result for patients. When I help a patient, it makes me happy because I see that I help them bite better and feel more confident with their smile. It's like with friends and family. where we wish each other well and want them to be happy in their life. Even if we are just a small part of their journey, this alone brings us joy. I want everyone to see that a university in the south of Thailand can effectively handle complex cases. It also allowed me to undertake new challenges that I have never encountered before, providing valuable experience. I believe Thailand offers freedom because female dentists can work alongside male dentists. My colleague is so kind and everyone helped me. I am getting married soon. My partner is someone who cares deeply about every detail of my life. He supports me in my work and career, listens attentively to my concerns, and is always there to help. I am grateful for his presence and how he completes me. I'm pleased to have him by my side.
Hello, I am the Dr. Gonzalo Navarro from Managua, Nicaragua. I am a specialist to the dental implants. I have a master program. And when I was a child, I liked the principal idea to health care in a dental office. So my first visit that was successful, that was good for me, that was an easy treatment, and enjoy it. Then, passing the years, I studied dentistry and involved to the new world, to the dental implants world. My principal mentors was the Dr. Luis Jaime Arguello and the Dr. Luis Douglas Contreras. They all time try to my dental implant practice increase and better because they know that I all time try to efforts to create the best treatment for my patients. I'm motivated to compete again in MegaMind 2026 because I trust in this platform. This is a big platform for connect the world, connect other doctors, and connect every kind of topics for dental implants. So I'm here, I'm in MegaMind again. I try to be efforts again to my cases, to my all different kinds of treatments for my patients, and to share this information for the world. Thank you so much. Keeping a smile, and remember, this is MegaMind.
Hi, I'm Dr. Mustafa Jamil. I'm a periodontist. I born in Egypt and I spent my whole life in Cairo, Egypt. My private practice, I have 3 clinics and I'm starting all my way working in Egypt. I started my faculty of dentistry studying in 2005 and I finished my PDS on 2010. And I started in 2012 after finishing my residency, going with a master degree program, working with my master degree thesis on the sinus lift, trying to dig into the field of sinus lifting, how to do the sinus lift, the open and closed approach. Starting my day early morning at 6 a.m. to have a chance to meet my kids before going to school and taking them to the bus where they go to the school. Then starting my day with a fresh shower and go to mosque to have my prayer, and then I read part of the Quran. Then I take my car and go to the gym. In the gym, as you know, our profession is very, very tough with a lot of stress, so we need to to relieve this stress with the gym. After the gym, we have to go to the pool to relieve with the cold. Then I'm ready and fresh to start my clinical day and see my patients. While I'm in the car, I'm starting talking to my receptionist and check do the patients are ready or not, to talk with my team to prepare everything for our day. As you know, the dentist is like a family member. We are trying to build a good relationship with our patients. It's not about money, it's all about reputation, about delivering the best for your patient. Especially when we are talking about implantology, it's not a hit and run. Most of our cases may take 1 or 2 years to finish, from augmentation, soft tissue and hard tissue, temporization, scans. It's a lot of work. So if you don't have the ideal relationship, a clear relationship between you and your patient, you will suffer a lot and the stress will be much more. After that, it's very important to communicate with your team members. To improve the quality, it's not about you, it's about how you're gonna deliver, what your goals as an institution, what the goal of this, how to prepare our patients, how to prepare our schedule, how to make everything comfortable the best way for our patient. Apart from the clinical work, I'm dedicating a very large part from my life for education. We are working with the Advanced Implant Program. We have a lot of young dentists who are aiming to learn implantology from basic to advanced. Regarding MegaMind, from where did I know about MegaMind? For me, it's a brilliant idea. So you are connecting young implantologists to share their own cases together. It's not only about selling implants, it's about improving the quality of not only dentists but also speakers. So MegaMind, they are creating a future speakers. So the idea was brilliant. Why did I apply for MegaMind? I found that it's a great opportunity to network with.
I am Professor Pongsettakul. I am the Dean of the Faculty of Dentistry, 𝐀𝐒𝐈𝐀 University, Bangkok, Thailand. My specialty is oral and maxillofacial surgery, and my passion is education, research, and inspiring the next generation of dental.
Let's start. Good afternoon, respected judges and colleagues. It is an honor to be here today. My name is Dr. Kannika Bureekanchan from Thailand. Today, I would like to share a case that demonstrates intentional planning from day one. One extraction, one implant, one stable smile. This patient is a 39-year-old Thai female who experienced dental trauma following a motorcycle accident. She came to our clinic approximately 2 months after the accident, complaining mainly of a fracture involving tooth number 13. At the initial assessment, fracture of tooth number 13 were identified. Prior to visiting our clinic, the patient had received initial restorative treatment on tooth number 12. Clinical examination showed loss of coronal tooth structure of tooth number 13 with pulpal involvement. The fracture line extends from the incisor edge toward the subgingival area, with visible less pulpal tissue at the fracture site. Tooth number 13 remained in normal alignment within the dental arch with no clinical sign of displacement. intrusion or extrusion from both frontal and occlusal views. After that, I sent the patient for a CBCT scan. CBCT showed a longitudinal crown root fracture extending below the bone crest. The buccal plate was extremely thin, 0.49 mm. Based on clinical and CBCT findings, tooth number 13 was diagnosed as a complicated crown root fracture and non-restorable tooth, indicating extraction and implant placement. Tooth number 12 remained restorable despite a crown fracture and discoloration. Endodontic treatment was planned. In this case, immediate implant placement was not a choice, it was the proper treatment. Immediate implant placement can shorten treatment time and help preserve soft tissue contour, especially in the dental papilla, resulting in improved immediate aesthetic. However, it is a technique-sensitive procedure and carries a risk of mucosal recession, particularly in thin bone phenotypes. For this reason, precise planning and experienced execution are critical. The main challenge in this case was not simply replacing the tooth, but preserving the extremely thin buccal plate, which measured only 0.49 mm. A thin buccal plate is well known to undergo significant resorption after extraction. This case clearly represents a high-risk situation of post-extraction bone collapse. Given the extremely thin buccal bone, soft tissue stability became a key determinant of aesthetic success. While soft tissue augmentation is important, there are 4 key clinical benefits. It significantly improves aesthetic outcome of implant placement. Number 2, while it has a limited effect on marginal bone level, it enhances gingival health and support better plaque control. 3. A wider zone of carotenoid mucosa help in reducing mucosal recession. And 4, most importantly, it ensures stable clinical, radiographic, aesthetic, and patient-report outcomes over the medium to long term. Previous clinical study by Professor Khan et al. Have shown that connective tissue grafting performed at the time of immediate implant placement can increase gingival thickness and help maintain the gingival level in the aesthetic zone. Therefore, soft tissue augmentation was intentionally incorporated to reduce the risk of recession and improve long-term aesthetic outcomes. Today, soft tissue augmentation during immediate implant placement is commonly achieved using 2 techniques. The first one is the subepithelial connective tissue graft, or SCTG, and the second one is the de-epithelial connective tissue graft, or DCTG. For the SCTG, this approach may result in less lamina propria because a part of it remains attached to the epithelial layer that we are trying to separate. As a result, the graft may become richer in adipose and glandular tissue. It may reduce the quality of the graft. For DCTG, is obtained by removing epithelium from free gingival graft. As a result, the graft may compose mostly lamina propria with minimally submucosa. It provides a dense collagen-rich structure. From this systematic review and meta-analysis at 1 and 5 years of follow-up, coronally advancement flap combined with the epithelial gingival graft show higher mean loose coverage, greater carotenoid tissue gain, and better clinical attachment gain compared to coronally advancement flap with SCTG. So, clinically, this suggests that the epithelial gingival graft approach may provide more stable and superior long-term outcome. Here, a quick comparison of DCTG, SCTG, and soft tissue substitute. So in this case, I showed DCTG. So this case follows one fully integrated concept. extraction of tooth number 13, immediate implant placement, immediate provisionalization, and soft tissue augmentation, all aimed at preserving hard and soft tissue contour and achieving a stable, long-term aesthetic outcome from day one. We use a tooth gauge to place the implant in a precise, prosthetically driven position. In this case, a MegaGen Blue Diamond implant was selected. The implant features a deep and nice thread design, which provides excellent primary stability, particularly in immediate implant placement. A MegaGen Blue Diamond deep thread implant I used diameter 4.1 by 13 mm was selected and planned to engage the palatal and mesial bone to achieve optimal primary stability. Let's get started. Tooth number 13 was carefully extracted using an atraumatic technique. After that, the surgical guide was tried to confirm proper fit and positioning prior to implant site preparation. After implant placement, we achieved excellent primary stability with an insertion torque 45 nCm. This allows us to proceed with immediate provisionalization. The provisional crown was placed on the same day, not for function, but to support the soft tissue, especially interdental papilla from day one. We shaped the tissue early, not after its collapse. This is the provisional crown used in my case, and it was designed based on EBC concept. The E zone is convex to support the gingival margin. The B zone is concave to provide soft tissue augmentation, and the C zone is straight to support crestal bone stability. This contour design helps guide soft tissue healing and maintain a natural emergent profile around the implant. After provisionalization, soft tissue preparation was performed. A labial pouch was created at tooth number 13 using a channeling knife, following the direction shown in the image. The graft was harvested from the palatal gingival. Subsequently, I removed the epithelium from the connective tissue graft. Unfortunately, clinical photos of this step were not available. I'm so sorry. So I will explain using this image. After the lip pouch was created and the DCTG was secured, gap grafting was performed using xenograft to support the buccal contour and preserve the hard tissue. This image shows the immediate post-operative radiographic and clinical outcomes. Both enhanced soft tissue appear stable, and the results are consistent with the planned treatment. These pictures show a stable and well-balanced aesthetic outcome with good soft tissue support around the provisional crown. At 2-week follow-up, the sutures were removed, healing with no sign of inflammation, and the provisional crown remained stable with no mobility. At 6 weeks follow-up, the soft tissue remained stable and well measured. From the frontal, lateral, and occlusal view, the contour continued to appear healthy and well supported. At 4 months, this was the right time to take the final impression for the definitive crown. The soft tissue was stable and well measured. Shade selection was done intraorally to match the adjacent teeth and ensure a natural final outcome. On the X-ray, the bone looks stable and clinically, the soft tissue contour looks healthy. This is the result of controlling the hard tissue, soft tissue, and provisional restoration from day one. As you can see here, the emergent profile is very well shaped, stable, and highly aesthetic. This is exactly the goal of our approach, a stable, natural, emergent profile from day one. Now it's time for the final crown. This is the final crown in the frontal view, showing harmonious and natural aesthetic result.
This close-up view highlights good soft tissue integration and a natural gingival contour around the final crown. The lateral view shows excellent tissue support and aesthetic integration. This occlusal view shows smooth and continuous gingival contour, supporting a natural emergent profile. At 6-month follow-up, the clinical outcome remains stable. The soft tissue contour is well maintained with no sign of recession or inflammation, and the emergent profile remains harmonious in all views. Lateral occlusal view and lateral view. This one-year result confirmed that controlling hard tissue, soft tissue, and prosthetic from day one can deliver long-term stability in the aesthetic zone. Considering the initial buccal bone place was only 0.49 mm, this level of bone preservation is very favorable. At 1 year, the lateral and occlusal view remain stable and well supported. 1 year, stable tissue, stable aesthetic, one stable smile. Conclusion. From day one, precise computer-guided implant placement ensure ideal 3D positioning. Immediate provisionalization with deeper line connective tissue graft was used not for speed, but to actively shape and stabilize the peri-implant soft tissue at the earliest stage of the healing, especially interdental papilla. With the EBC concept, a natural and stable emergent profile was maintained over time. This case shows that long-term soft tissue stability is not achieved by chance. It is the result of intentional planning. And when every step is planned from day one extraction, one implant, one stable smile. Thank you for your attention.
Recording stopped.
Thank you for your presentation.
Thank you.
Thank you. Thank you very much, Kanya. You outline a very clear and well-documented case. And
thank you.
Your pictures are very clear also. Thank you very much.
Thank you.
Yes, Kannika, it was very nice. That I was worried about the aesthetic problem, but you did it very nice. Congratulations, it was fantastic. Thank you very much.
Thank you.
Thank you very much.
everyone. It's such an honor to be here again in 2026 of the MegaMind. So I'm Dr. Ongart Puttipisitchet from Bangkok, Thailand. Actually, I'm the prosthodontist. So today's topic is about the 3P of the roller coaster experience of the implant, skull loosening, and the crown removal. So 3P stand for the pitfall and the principle and the prevention. If everyone ready, yeah, just take a ride of the roller coaster with me. So talk about the implant prosthetic journey. Yeah, mostly or basically we start with the implant planning, the implant surgery. Yeah, and my major part is the prosthesis delivery. And at last, we need to educate the patient how to treat or take care of their prosthesis. But unfortunately, we have many errors in the planning step and in the surgical step that leads to the problem of the misfit of the prosthesis that my major work. And then they lead into the consequences of their many complications. So for the complication in dental implant, divide into the biological complication, such as the early or the late stage that divide into by time. The causes come from trauma, infection, or overloading, or even the inflammation or the poor oral hygiene of the patient. How about the mechanical complication, such as skull loosening and the fracture of each component from the abutment of the screw or of the fixture? So about the mechanical implant complication that I mentioned is about the abutment skull loosening, the fracture of the screw, and the abutment and the fixture fracture. The incidence rate is about 6 to 12%, 4%, and 1% respectively. Yeah, how about the problem of skull loosening when it happened? How about the management that patient expect from us? For the anterior area, they expect for the aesthetic. For the posterior, they expect for their become the normal function, and including their social activities, for the dinner, for the lunch, and the work, and their health in digestive system. So both of these areas are very important when the skull loosening happened. So coming to the 3P for the skull loosening, that include pitfalls, principle, and the prevention. So pitfall in my terminology, because nowadays some implantologists know how to install the implant and deliver the implant prosthesis, but some of them never know how to retrieve the skull loosening if it's happened, or even the worst case for the fracture of each component. So let me start with the case number 1. 33 years old female patient come to see me with her chief complaint of the lower anterior implant crown had mobility for 2 to 3 days. Actually, when we trace back the dental history, 3-2 implant crown was done from another country or abroad country for 5 years ago, and patient moved to Bangkok for her long-term residence. Yes, when I find her, when take the look closer from this video, we find that 3-2 implant crown was moving and have a mobility. And then we take a look at graphic examination, a bit stop and stunning. And what I about the position, 3-2 my position of the implant crown. And this is the screw retain. And for the vertical dimension, so it's line. For the labial lingual, it is too lingually. That affect the design of the and the overloading from the biomechanical of the cantilever. And actually, patient feel a little bit of the tongue irritation from the implant crown position. So see that skull loosening. And when we take a look in the labial side, we find the pink porcelain that may affect the poor oral hygiene because the difficulty for the cleaning. So The second P is a principle. The question is how we can give an emergency treatment. So I give you 3R. First R is remove the fillings and retightening of the screw back and then refilling of the screw access. But as a prosthodontist, I find some problems such as the very limited space or the inadequate height or space of the screw. So the question is how to increase the screw filling retention. From the paper of the Schoenboom, recommend us that if you want to increase the retention, use ibuclean for 20 seconds, rinse and dry, and then you put the PTFE or cover the screw head and bond the surface with the monobond for 60 seconds, and then put the composite filling and polishing. Then that's what I gave it to the emergency treatment for her in 2022. But it is not only one time, for repeated being many times. So the second screw loosening happened in 2025. So I give her the option about the ideal treatment plan, about implant removal, and the new implant ideal position with the SCRP or screw cement retained crown. But she just afraid, she just want to observe. So I just give her warning that maybe screw can fracture in the future. So the third P is a prevention. Prevention for screw loosening, you have to do, first P is proper torque, precise value by retightening every time. Second P is prosthesis fit. Please X-ray every time for the passage fit of the abutment and the implant connection. And lastly, for the prosthesis design, proper dimension, not implant implant, but the prosthesis is very crucial. For the retrievability, we should use the screw retain type. Yeah, this is my first case. Coming to the second case, trace back to 2017. This patient come to see me with a 70 years old male patient. His chief complaint is unable to chew properly from the severe wound of the posterior teeth. So the dental examination and history was done. We find many leakage of the large fillings, many missing teeth, 16, 12, 26, 35, 47, and malalignment of tooth, and 18 is the non-occluded tooth. But important thing, as an implantologist, we find that 46 is a crown on the implant that done more than 10 years before with the porcelain chip. And this is a cement retained type. So as an implantologist and prosthodontist, I do the diagnosis for many teeth, for the restoration plan for the crown and the bridges, and for the extraction 18, 28, 38, and 48. How about the 46 implant crown? I plan to remove the crown and make a new crown. The reason that we need to remove the 46 crown implant because porcelain chip, gingival recession, the patient concern. And the very important thing is this case plan to do the full mouth rehabilitation. So the new occlusal vertical dimension was planned for setting to change the occlusal plane. So from the start and the transitional stage, we increase the OVD of the patient with the temporary crown and the bridge and modify his occlusal plane. And patients still satisfied with this condition. Then the important phase is my part. I have to remove the implant crown. So I use the diamond and carbide burr to cutting the implant crown. But unfortunately, at that time, 2017, I have no idea what happened. I cannot find the screw head of that abutment. So I try to fight to retrieve it more and more. Then the moment of rush comes to me, and I just feel rushed. I want to remove the implant abutment. But unfortunately, I cut more and more until accidentally deep into the fixture a little bit. And I feel a lot of anxiety and fear. Yeah. And if we are in the roller coaster, we find that we are at the top of the feelings of the rush and the anxiety. So the pitfall of this kind of case in 2017, it's I cannot recognize of the abutment type. Actually, this abutment type called the solid abutment. The absence of screw head, only abutment body that present. So I stop the treatment and then I go back to the principal. I find that they have a rescue kit that for the damaged solid abutment. We can retrieve it with this tip. We use the extraction bolt, turn counterclockwise or reverse way. And then when I fry this manual, then I go back to the patient for the second visit, and then I use extraction bolt, and it's very easy to retrieve it. And I plan to make a new abutment and the ground with the screw cement retained for the excellent retrievability. So this is a picture from the start and the final state of the prosthesis with the mini crown and bridge and the implant crown. So this is the occlusal wheel from the top and the bottom when we finish the prosthesis plan and the procedures. This is 1 year follow-up in 2018. And patients still satisfied with the result. Yeah. And then every time that I recall the patient talk about his experience about when I retrieve the implant crown. Come back into the principle. Nowadays, this year is 2026, right? If I can go back, turn back time with the updated technology, the question is how the technology can improve the treatment of the cement retained crown removal. So I have two techniques that can share with you. First, we call the CAD/CAM screw locating guide, and the second technology is laser. Start with the screw locating guide, how to register and retrieve the screw access hole in cement retained by using the 3D CBCT and intraoral scanner and the CAD/CAM technology to create the screw locating guide. This paper was show us the method. So they merged the file of the intraoral scanner STL file with the CBCT. They superimpose it, and then they give us the visual guide of a screw access hole. And then we design the screw locating guide and fabricate it with the clear acrylic template. And when we apply on the patient, put it on top of the screw loosening crown and then drill, follow with the screw locating guide. That can give us the less destructive and excellent retrievability without destroying the crown and the abutment. The second technology that I find and published just only last year from Whiskey, using the laser of the waterless, to retrieve the cement retained type of the zirconia crown. This video shows us that how the laser work with the veneer or even the crown by separate the bonding of the resin cement from the veneer or the ceramic from the natural tooth. We can apply this technique to remove the crown on the implant abutment. And this paper confirmed us that the waterless technology with the laser can improve our quality of the implant crown management. For this loosening could affect both biological and mechanical complication and reaction in acute and chronic way. For the biological reaction from screw loosening, we find that at first, patients feel red gingival margin, foot impaction, chronic inflammation, bone loss, and eventually implant loss. For the mechanical reaction, we find some fracture of screw abutment. Luckily, I can apply the MacGyver kit to improve the quality of this treatment. And if I have a good luck, I can share my experience in the course in Thailand in MegaMind 2026 about to unlock my potential and test my mind again in Toronto. So conclusion, 3P for screw loosening, pitfall, principle, and even prevention with the updated technology with CBCT, iOS, and CAD/CAM and laser to improve the quality of a complication management. This is my references. And thank you again for the MegaMind 2026. Thank you very much.
Recording stopped.
Thank you for your presentation.
Thank you.
Thank you for the presentation, Ongart. Nice to see you again in the competition, and wish you luck for the Toronto.
Thank you. Thank you. Nice to see all of you here.
Okay, how about Professor Krasny?
Thank you, Doctor. I think it was a great idea to the title of your lecture, because I think we know very little about the mechanic problem in the implantology, but you can talk about it. Fantastic. Congratulations.
Thank you. Yes. Yeah. In Thailand, the MacGyver, I really like the MacGyver kits. And yeah, I used to present it in 2024, but at that time I have very less of the experience. But after I conduct the course in Thailand, I want to show more and unlock my potential again. If I have a good luck, I can show it with the 2026 in the Toronto state. Thank you.
It's called could you say Maxilla, or in your factory you have very nice box to fracture of implant.
MacGyver.
MacGyver. Thank you very much.
MacGyver.
I have it. MacGyver.
Yes, yes.
Yeah.
It was nice.
Yeah, he's the the speaker in Thailand about the MacGyver kit. So
And
yes.
actually, one thing I talked to Dr. Park about the waterless also. That's why I turned to interest in waterless, because I just visit the MacGyver MegaGen factory last month, and one session is the laser, and I just know that MegaGen they own the BioLess laser. Yeah, and I take a look very close, and I'm really interested in this technology to improve my patient treatment. So now I think I order, maybe next month I will order waterless to remove many processes.
Okay.
Okay, I'm ready.
Yes, please start.
Okay. Good afternoon. Thank you, Megamind, for hosting this wonderful event, and thank you, dear judges, for your valuable time. It's such a great honor for me to be here doing this presentation today. And a little bit about me. I'm Dr. Esmond Siagian. I'm a periodontist and implantologist from Jakarta, the capital of Indonesia. And today I want to share my presentation about Plan Before You Plant, peri-implant aesthetic management for predictable outcome. Let's start. What is aesthetic? In general sense, aesthetic refers to the branch of philosophy dealing with the nature of beauty, art, and taste. Aesthetic is about balance, harmony, proportion, symmetry, contrast, and unity. And is this harmony? Is this balance? Back in the day, many years ago, where I started doing implant in aesthetic case, I began to learn about bone grafting around the implant and soft tissue augmentation, but I end up with these results. Recession on the gingival margin, uneven margin line, loss of interdental papilla, etc., etc. I could not find the proportion, harmony, and balance in these results. It was so difficult back in the early years, sometimes make me very stressful when the patient came to the office and want to get implant treatment in aesthetic area. And what about today? Let's see example of this aesthetic dental implant case. After evaluation, we need to extract and replace tooth number 12, 11, 22, and 23. How to put dental implant in this patient? How do I handle aesthetic implant case now to prevent failures like the case in the previous slide? The first question came to my mind before doing implant placement would be where to put the implant fixture. But before I decide to put the implant fixture, I should first plan where the final soft tissue margin line will be. And if you can see the imaginary line, the yellow line, is this yellow soft tissue margin line really good enough? Maybe yes, if we only see this picture. But when we try to zoom out and try to see the bigger picture, this yellow margin line is slanted because the patient already have a canting smile. We need to achieve new soft tissue margin line for this patient. So seeing bigger picture is the first step and important for aesthetic case. So this is why. Plan before you plant. Before we insert the implant fixture, we must plan where the future margin of the implant restoration. This is really important because you don't want to have case like this without planning, without doing a proper implant and scratching your head trying to figure out how to restore implant like this with recession this much. And to plan it, we must understand what kind of implant margin therapy and what kind of professionalization that we will discuss after this. Like Benjamin Franklin once said, if you fail to plan, you are planning to fail. If you fail to plan your implant, you are planning to fail in your implant case. And today I want to share my thought and story how I developed the strategy and got more predictable and stable outcome. I will discuss three main topics today. Is about the soft tissue margin, professionalization, and the fundamentals. And to describe about these three things is the soft tissue margin therapy. And then the second one, the professionalization, would be the type of professionalization that we will use. And the last one is fundamental about the perioprosthodontic fundamentals. You can find this framework in the article, a beautiful article published by Dr. Jonathan Esquivel et al. About timing implant professionalization, which discuss about the fundamentals for tissue conditioning and stability. Let's start with the soft tissue margin therapy. It's only two, which is preserve or reestablish. Preservation is when we don't need to modify the margin outline, and reestablish is when we need to modify the margin and contour to get the ideal final results. Preservation is only when the ideal tissue outline is already exists, and sick phenotypes, and we don't need to do connective tissue graft during the immediate implant placement, and their professionalization strategy involves a passive full contour professionalization. This case with preservation therapy is very simple. It's quite simple, but very rarely. Maybe for me personally, less than 20% of my aesthetic patient is only preserved. Most of the time, I do the margin reestablishment therapies. While in margin reestablishment therapies, we have another story. we have delayed implant case, which is case presenting bone dehiscence with or without recession. The second one is the immediate implant sites with apically positioned gingival margin. So we need to move the margin more coronally. The third one is with the coronally positioned gingival margin. So we need to move the margin more apically. And the last one is when we already have an ideal tissue contour, but with thin phenotype. So we still need to modify the phenotype to minimize the risk of recession. And we can continue to the provisionalization, which contain of 3 categories, which is passive, active, and subcontour. And the difference between them is their relationship in their emergence profile with the underlying tissue, which may promote apical, coronal, or no displacement at all. To better understand about this, and I believe many of the doctor before me already discussed about this, is about the EBC concept. Just this year, Dr. Ramon Gomez Meda, Dr. Jonathan Esquivel just published a new concept, the 2.0 concept about the EBC concept. And from that, we understand that we must have 3 zones, the crestal, bounded, and aesthetic. But to make it simple, the crestal must be as straight as possible. The bounded should be as concave as possible. And then the aesthetic should be as convex as possible. And after understanding this, the crestal, bounded, and aesthetic, after refresh our memory about that, I want to continue to the provisionalization. First is the passive full contour provisionals, where the restoration E-zone and margin line set at the level of the ideal zenith point. So without exert pressure on the underlying tissue, preserving the existing tissue outline is the primary objective. So this is ideal for the preservation therapies. And again, this is a very rare case, not very rare, but very rare case. Many times we cannot use this passive full contour provisionalization. The second one is the active full contour provisionalization, used to reestablish the future ideal gingival architecture to move tissue more apically. So we put pressure on the E-zone, and the ideal zenith point will move more apically because we put exert pressure on that area. And the last one is the subcontour provisionals. We use this if we want to move the margin more coronally. The subcontour provisionals are passive provisionals, as their zenith and E-zone are set coronally to the ideal position to allow space for soft tissue creeping and grafting. And this is ideal to move the margin more coronally. Why I only talk about provisionalization? I don't talk about the stock healing abutment, because nowadays we knew that we need to put the implant fixture more palatal to leave space for the tissue and to be able to have a screw retain restoration. But if you use stock healing abutment, you can see how big the gap at the labial side. The tissue will have no support, and soon it will collapse, and we will lose all the advantage of doing immediate implant placement. So this is how stock healing abutment, in my perspective, in aesthetic case. In peri-implant aesthetic management, the use of provisional restoration will give the most ideal outcome compared to the stock healing abutment. And the last one is the perioprosthodontic fundamentals. We can divide into 3 categories, which is space, volume, and time. I believe we already understand about the space, which is the implant 3D position and the material selection, etc. The volume is about the bone and soft tissue phenotypes. That will decide when we need bone grafting or soft tissue grafting, or instead we need to do gingivectomy with or without osteectomy. And the last part is the time. Time is osseointegration time and soft tissue integration time. And time is what I don't have now, only 50 minutes. So maybe next time I will dig deeper with this discussion. Now I want to share to you what is the results if you put the implant ideally based on the concept that I already discussed. In one of my clinical case, this 40-year-old female patient came to my office. She wanted to improve the condition of her teeth and want to have a fixed restoration. And this is the initial condition of her teeth. It will be easier if we do orthodontic treatment first, but the patient refused for ortho. And another reason is because the patient lived far away around 2 hours from her place to my office. And also, maybe it will be easier if we do just extract all the teeth and do all on X on the maxillary region. But the patient is 48-year-old, is still middle adulthood. We need to preserve the remaining teeth as long as possible and only extract the unrestorable tooth. So because the subgingiva caries and the remaining roots on the tooth number 12, 11, and 22 and 23, we extract the 4 of that tooth, and because the limitation of the mesiodistal space in 11 and 12, we decide to put one implant in tooth number 11, cantilever pontic in tooth number 12, and immediate implant on tooth number 22 and 23. So let's start with the framework that we already discussed. This case is immediate implant sites with coronally positioned gingival margin. So what is the scenario for our patient? The soft tissue margin therapy will be re-establishment therapy because we need to establish new soft tissue margin. And the professionalization will be active full contour professionals to move the soft tissue margin more apically, more upwards. And before I start, of course, I talk about plan before plan. So I plan very carefully, following the digital smile design. We plan and design the surgical guide for implant and gingivectomy. We have opted for the gingivectomy without ostectomy because we can see from the gingivectomy guide, the guide doesn't intervene with the bone. Even after we do the gingivectomy, there's still leave a good soft tissue before it touched the hard tissue or the bone. And then the day of the operation, we do gingivectomy guidedly to achieve optimal results. And then only after the gingivectomy is finished, we do the extraction. And then we change the guide to surgical implant guide and insert the implant fixture guidedly, at least 4 mm from the fixture of the margin line vertically. This is the reason why we do gingivectomy first, not after the implant placement. Also, the implant fixture position is measured 4 mm horizontally, and we put some biomaterial, which is allograft in this case, for grafting the labial bone gap. But unfortunately, we could not get the ideal insertion torque for tooth number 22 and 23. But for the tooth number 11, we get good primary stability and continue right away for immediate provisional restoration. So this is gonna be the picture that we only see about the tooth number 11 and 12, because that's it. After we understand about the EBC concept and the workflow, this is all what we do on these tooths. And just make sure it accordance to the EBC concept and relieve the contact on the incisal area. And for the pontic, I have no time, but the framework I choose for the pontic design, but due to time limitation, I could not discuss deeper about this. And then 3 months post-op, we do re-entry for the tooth number 22 and 23 to put the new provisional restoration by making the labial roll flap first to push the flap more labially, and then insert the PMMA crown. As you can see, the margin line is not that very good, but don't worry, we can still modify the active full contour provisional. We put again some pressure on the margin line so we can move the provisional restoration to move the margin line more apically and get a more aesthetic results. And then this is 6 months post-op and before taking the final impression. This is the emergence profile 7 months after the operation. And the time of the delivery of final crown restoration, again following the EBC concept of the final crown restoration. And this is immediately after final restoration. You notice there's still lack of papilla head, redness at the crown margin, but be patient and trust the polyzirconia restoration. Give it time to fully heal. And the final results, 8 months post-op, we can see the contour is really good now. And this is the periapical X-ray. There's no bone loss. And then this is the final result 10 months post-op. This is the emergence profile before and after. and intraoral before and after. This is the extraoral before and after. The patient really happy for the result that she got. So aesthetic, function, and biology combined will shape your final results. Like Albert Einstein said, everything should be as simple as possible, but not simpler. As simple as possible, as complex as necessary. For the conclusion, plan before you plan. Understand about the EBZ zone and peri-implant biology is essential. And understand about the perio-prosthodontic fundamentals. Terima kasih. Thank you very much.
Recording stopped.
Thank you for your presentation.
Thank you very much, Dr. Esmond, for truly appreciate your presentation because it's highly documented and very smooth transition for the slides and very scientific also. You documented very scientifically and described. This is very good for storytelling and to engage the audience. So I appreciate your presentation. Thank you very much.
Thank you very much, Professor Glenn.
Thank you.
Thank you, Doctor. I have a question. Everything was clear for me. Fantastic photo, fantastic document. Congratulations.
Thank you, Professor Cornell.
Shall I begin? Okay, I'm Dr. Nago, a general practitioner practicing in Okinawa, Japan. Thank you very much for giving me this valuable opportunity today. I'd like to share our group's approach. Before sharing my clinical outcomes, allow me to briefly organize the key concepts. This represents the traditional treatment sequence, typically taking over 1 year to complete. Procedures involving GBR lead to extended treatment timelines and require multiple surgeries. In contrast, my mentor, Dr. Hayashi, advocates for minimalism in implant dentistry. By adopting this philosophy and the approach, most treatments can be completed within 4 months. We must ask ourselves, is GBR always a necessity? Minimalism in implant dentistry is a philosophy focused on achieving maximum biological results with minimal surgical intervention. Minimalism is not about cutting corners. It's all about achieving the best results with the least biological cost. One reason GBR was widely performed was the belief that the bone was necessary beyond the implant length. This article compared the necessity of bone graft when sinus floor elevation. It showed that no apical bone engagement is required beyond the implant length. Should we continue to do grafting, especially when success is achievable without grafting? Also, denser bars has drastically changed the indication of sinus lift and the necessity of bone graft. Many articles show combination of denser bars and short implant may avoid the use of bone substitute. In Japan, Dr. Hayashi wrote a sensational article in 2022. For extremely limited residual bone height site, place ultra-wide diameter short implant without any foreign graft material. This new method allowed shorter treatment time without the risk of sinusitis. When doing intentional perforation, the thinner the drill, the better. Even if we perforated the bone of sinus floor, it does not mean the Schneiderian membrane is absolutely perforated at the same time. Even if a minor perforation occurs, we can screen out the small hole by clot that includes old bone cuttings. The healing process maximizes the osteogenic, osteoinductive, and osteoconductive abilities of the native tissue without the need for foreign graft substitute. Even a full perforation is no reason to abort. Proceed with graft-free placement, as the implant itself effectively seals the communication between the oral cavity and the sinus. Multiple studies confirmed that the membrane perforation has no significant impact on the final success rate. It justifies the shift toward graft-free procedures, utilizing the patient's own healing potential instead of artificial substitute. As a tentpole, the implant maintains a space where the blood clot scaffold allows osteoblasts from the sinus floor to form the new bone. Before we discuss the main challenge case, let's look at the simpler reference case. The patient needed full arch rehabilitation, but please focus on upper molar side today. We can see significant buccal-palatal ridge resorption due to long-term tooth loss. X-ray also showed the vertical bone height was also significantly reduced. Only 4 mm was available. In such cases, the conventional approach would typically begin with GBR, but we, Dr. Hayashi's group, employ a completely different approach, grafted sinus floor elevation. This was the immediate post-operative CT scan, implant placement with grafted sinus floor elevation. I could not choose ultra-wide diameter implant because buccal-palatal ridge was limited. I chose the shortest 7 mm length implant beyond the original bone height 4 mm without augmentation. On the right-hand panel, saline from the osteotomy is clearly visible inside the sinus cavity. However, the entry of saline alone poses no risk on clinical complications as discussed. 2 months after the placement, ISQ value was raised, successful osteointegration was achieved. Here is the CT image at post of 1 year. As you can see, the new bone was creeping up and adapting to the implant surface, even beyond the original 4 mm bone height. Also, sinus was very clear. This was clinical outcome achieved with graftless sinus floor elevation. Now, let me move on to my main case today. The patient came to my office claiming his back tooth was chipped, but actually the tooth was cracked, medial distal crown fracture. Cross-sectional image showed vertical crack on occlusal surface that reached root falcation. So it was diagnosed as crown and root fracture, which meant extraction was indicated. CT images showed bone resorption around fracture tooth, more than 10 mm mediodistally and buccopalatally. That meant even the widest 8 mm ultra-wide diameter implant could not get initial stability. In this kind of situation, immediate placement was contraindicated. In my earlier practice, I have relied on conventional bone augmentation. But now in Japan, as seen in the simpler case we just reviewed, we take another way. Extraction without curettage and early implant placement without augmentation. When severely inflamed, infection prevention should be the top priority. The simplest approach is to wait about 8 weeks post-extraction. Subsided inflammation and onset of remodeling makes this the optimal time for early implant placement. The non-curettage approach is consistent with current minimally invasive periodontal trends. Granulation tissue is rich in growth factors, so preserving granulation tissue without curettage leads to faster regeneration. Also, understanding the healing of extraction socket will lead to decisions about the appropriate and reasonable timing for the following intervention. When we don't perform immediate placement, we don't remove the granulation tissue, we preserve it. This accelerates tissue recovery in both early and delayed placement. Wait 8 weeks and place the implant during the modern stage, which is the callus formation phase. Maximizes the healing potential. It is more logical than waiting for new osteotomy and saves significant time. We use denser burrs not only for osteodensification, but to achieve precise circular osteotomy, not oval. Precise circular osteotomy combined with spring-back effect enhances primary stability, even in compromised bone conditions. This level of mechanical engagement is unachievable with conventional oval-shaped preparations. Developed by Dr. Hayashi, the selection guide drill is a specialized instrument used for final drilling before placing ultra-wide diameter implant. Its diamond abrasive size are designed to be perfectly compatible with the anyone implant profile, allowing for a precise and stable osteotomy. Combined denser burrs and selection guide drills ensures a precise circular osteotomy for optimal implant placement. Within Megagen Japan's education group, our commitment to precise circular osteotomy ensures intimate contact between the prepared socket and implant body, which is the absolute key to optimizing primary stability. Guided by these principles, we aim to use the full existing vital bone as a living tissue, regardless of how limited its volume may be. Let's wrap things up. In modern dentistry, even modern implantology, aggressive bone augmentation to accommodate long implants in the posterior maxilla is no longer mandatory. 3D finite element analysis proves that the implant diameter is more critical than length. Let me get back to my case. At 8 weeks post-extraction without curettage, the gingival tissue over the socket showed nearly complete closure. The following follow-up CT showed early signs of bone modeling and maturation within the site. Judging that the 7 mm diameter would ensure stability, I planned for the NE1 7001. Mark the starting point on the gum to the bone. Open the flap and remove the remaining palatal root. The gum was almost only 1 mm thick. Subcrestal placement might lose the implant by migration into the sinus. So, equicrystal placement Berkeley, ISQ value was 62, followed by ISQ value connected cover screw as two-stage approach. Place some synthetic bone discs around the platform, then sutured. Post-op actual view had confirmed that the implant was precisely aligned with the dental arch. The post-operative cross-sectional view had confirmed that sinus autografting was successfully performed, extending beyond the residuous bone height as planned. The sinus floor was intentionally perforated, but the membrane remained intact, as illustrated in this table. Uncovered 2 months after the placement, ISQ value raised but was just 70. Applied lab-made provisional, the ISQ further increased, then proceeded to the final restoration. Implant was placed after 2 months of extraction, and the final restoration was set after 7 months of extraction, 5 months from implant placement. The progress has been very good. X-ray after 1 year from implant placement. Radiographic follow-up. And comparison of CT images. Early implant placement worked well to gain sufficient autologous bone created to surround the implant both vertically and horizontally. Beyond my case, the Dr. Hayashi group has successfully treated hundreds more using the same technique, and we are currently preparing a publication to summarize these results. Here are other cases, courtesy of Dr. Hayashi. I would like to summarize the key points. Primary stability is the key to titanium implant success. Precise circular osteotomy works well by using these ideas and instruments. Round apex and lack of cutting flutes maximize membrane tearing and facilitate tenting. When bone height is limited, place ultra-wide diameter and shortest 7 mm long implant. Diameter ensures stability, avoids bone grafting, and reduces patient's cost. By believing in the power of vital bone and aiming for the best result with minimal intervention, we continue to strive in our daily practice. Thank you for your kind attention. Thank you.
Recording stopped.
Thank you for your presentation.
Dear Dr. Nago, the results are amazing. I mean, you have nothing, you don't have any bone,
Professor 𝐀𝐒𝐈𝐀 I am the Dean of the Faculty of Dentistry, 𝐀𝐒𝐈𝐀 University, Bangkok, Thailand. My specialty is oral and maxillofacial surgery, and my passion is education, research, and inspiring the next generation of dental leaders. To me, MINEC is not just a competition. It is a place where ideas grow and innovation thrives. I join because I believe in supporting young professionals who dare to think beyond the usual. When I was a student, we didn't have something like MINEC. Global platforms were rare, and opportunities to share ideas internationally were limited. That's why I value this so much. It offers the kind of chance I wish I had. For the next generation, MINEC is a gateway to connect with peers, to learn from mentors, and to share their vision with the world. It is a chance to grow, share, and truly make an impact. The real strength of MINEC is that it combines competition with collaboration. It's not about the winning. It is about learning, sharing, and building a community of innovators. I am looking for finalists who show skill, creativity, and a sense of responsibility. Ideas that are not only innovative, but also have the power to help people in real life. Believe in your ideas, stay curious, be bold, and remember the ultimate goal is to make a real difference in patient care and in our profession. Unlock your potential, test your mind, MINEC.
My name is Emilio Arguello. I am a periodontist. I'm originally from Mexico City. I finished my residency at Tufts University. I spent about 10 years of my life doing research, intense research, so I spent a lot of time studying that bacteria. And when I finished my program, I got invited to become part of the faculty at Harvard University. Now it's almost 20 years since I've been teaching there. In the early stages of my career, I joined the corporate industry, which is one of the largest DSOs in the United States today. Soon after that, I moved to Denver, Colorado, and that's where I practice today. And I joined a private practice. My time had been divided ever since between the corporate world, the academic world, and the private practice world.
Welcome to the Megamind 2026, Season 4, The Road to Toronto.
Megamind is a very good project, and I'm honored to be invited as part of that team because that gives the clinicians, especially the younger clinicians, the ability to foster an unbiased approach and knowledge, and not to become necessarily attached to a product or a system. And also another thing that I praise a lot for the project of Megamind is that they have paid a special attention to the people that judge are not necessarily affiliated 100% to a company and freely judge the cases that are coming through without that attachment to the industry. What am I looking for in that competitive environment? The most important thing is how were you able to serve your patient in the best possible way? Your train of thought help that person's life and improve that person's life. It's also important to think outside the box. If you are able to deliver the correct treatment to your patient, along with an environment that you were able to come around the problem by the open-mindedness of thinking of a potential solution, that makes the case even more interesting.
Okay. Do you like it?
My name is Dr. Beatrice Lang. I'm a practicing prosthodontist.
All right, so Maureen, how's the gum on the, it's healed up, right?
I've been in private practice since 2005. My journey starts with going to dental school here at the University of Toronto. When I graduated, I realized that I was not comfortable practicing yet. So I moved to the States and I did a year of hospital residency at Boston Medical. The 3 years when I was in prosthodontics studying, that's when I realized that what I learned in dental school was not adequate. It was just a lot. There were a lot of missing links. I've always wanted to be able to help people to connect those missing links that were always there. So I got the position to teach back at the same dental school that I went to. So now I've been teaching for the last 6-7 years.
Megamind is a global stage for aspiring dentists to compete for a chance to become the next generation of leaders in implant education.
Megamind Global Competition as an opportunity to improve on my public speaking skills. There was no age limit. At this point in my career, why am I doing it, right? Yeah, to me, it's every opportunity is an opportunity to learn from, whether it's good or bad. Why not just try it? What's the worst that can happen? You don't win. You walk out with new experiences, meeting new people, and I think there's always something good that will come out of this experience. You know, part of me is showing my sons that I'm still learning, I'm not perfect, I'm not afraid to try new things, and that I might lose, and that's fine. I like to do what I tell them to do.
Was lost and disappeared. What food you ate last night, how hard you bite the bone, remembering what I've told you.
My name is Dr. Ongart Puttipisitchet from Bangkok, Thailand. I have the experience as a dentist for more than 15 years, and my first dental implant experience started in 2010. At first, since a child, I don't like to be the dentist. I like singing, I like to be the artist. But because my family have a private hospital business, so I asked myself, why the good artist cannot be like an engineering created tooth in the dental field? At last, it's become the good combination for me. I like to go to church. We know that in the Bible, Jesus healed many peoples. I like to follow him. I can give the treatment as a healing for my patient as well, to be as a good Christian and good dentist. I find the Megamind last year, and I want to develop my presentation skill. Reaching the final round of the Megamind feels incredibly rewarding. Based on my first experience, I was able to reflect, grow, and come back stronger and better for this second opportunity.
Discomfort, pain, broken apart. Did you listen how to remove the way to save?
I think why I don't use the music as a part or the media to transfer this message of the dental implant to my audience. So that's why many people in Thailand know me as the singing dentist. This is my second time for the Megamind project. I will do my best for this time. and I looking forward to see everyone in Toronto 2026.
My name is Kannika Bureekanchan04. You can call me Dr. Joy. Since childhood, I have a dream of becoming a dentist because my mother bring me to hospital and I saw the dentist is so kind. I want to be like her. I graduated as a dentist in 2016 and subsequently worked at a government hospital for 2 years. After 4 years of performing dental implants, I graduated last year with a specialization in oral surgery and implantology. I attend the seminar and symposium in every year for treating to my patient because I want to help my patient in even better. Currently, I am working at Tung Song Hospital in Nakhon Si Thammarat province and at a private clinic in Hat Yai district. I believe that a professional dentist is one who combines both scientific knowledge and artistic skill to treat each patient uniquely. It's not only about having excellent treatment skills, but also about showing empathy and learning new techniques and knowledge to achieve the best result for patients. When I help a patient, it makes me happy because I see that I help them bite better and feel more confident with their smile. It's like with friends and family where we wish each other well and want them to be happy in their life. Even if we are just a small part of their journey, this alone brings us joy. I want everyone to see that a university in the south of Thailand can effectively handle complex cases. It also allows me to undertake new challenges that I have never encountered before, providing valuable experience. I believe Thailand offers freedom because female dentists can work alongside male dentists. My colleague is so kind and everyone helped me. I am getting married soon. My partner is someone who cares deeply about every detail of my life. He supports me in my work and career, listens attentively to my concerns, and is aware that to help. I am grateful for his presence and how he completes me. I'm pleased to have him by my side.
Hello, I am the Dr. Gonzalo Navarro from Managua, Nicaragua. I am a specialist to the dental implants. I have a master program. And when I was a child, I liked the principal idea to health care in a dental office. So my first visit that was successful, that was good for me, that was an easy treatment, and enjoy it. Then, passing the years, I studied dentistry and involved to the new world, to the dental implants world. My principal mentors was the Dr. Luis Jaime Arguello and the Dr. Luis Douglas Contreras. They all time try to my dental implant practice increase and better because they know that I all time try to efforts to create the best treatment for my patients. I'm motivated to compete again in MINEC 2026 because I trust in this platform. This is a big platform for connect the world, connect other doctors, and connect every kind of topics for dental implants. So I'm here, I'm Megamind again. I try to be efforts again to my cases, to my all different kinds of treatments for my patients, and to share this information for the world. Thank you so much. Keeping a smile, and remember, this is Megamind.
Hi, I'm Dr. Mustafa Jamil. I'm a periodontist. I born in Egypt and I spent my whole life in Cairo, Egypt. My private practice, I have 3 clinics and I'm starting all my way working in Egypt. I started my faculty of dentistry studying in 2005 and I finished my PDS on 2010 and I started in 2012 after finishing my residency, going with a master degree program, working with my master degree thesis on the sinus lift, trying to dig into the field of sinus lifting, how to do the sinus lift, the open and closed approach. Starting my day early morning at 6 a.m. to have a chance to meet my kids before going to school and taking them to the bus where they go to the school. Then starting my day with a fresh shower and go to mosque to have my prayer, and then I read part of the Quran. Then I take my car and go to the gym. In the gym, as you know, our profession is very, very tough with a lot of stress, so we need to relieve this stress with the gym. After the gym, we have to go to the pool to relieve with the cold. Then I'm ready and fresh to start my clinical day and see my patients. While I'm in the car, I'm starting talking to my receptionist and check do the patients are ready or not, to talk with my team to prepare everything for our day. As you know, the dentist is like a family member. We are trying to build a good relationship with our patients. It's not about money, it's all about reputation, about delivering the best for your patient. Especially when we are talking about implantology, it's not a hit and run. Most of our cases may take 1 or 2 years to finish, from augmentation, soft tissue and hard tissue, temporization, scans. It's a lot of work. So if you don't have the ideal relationship, a clear relationship between you and your patient, you will suffer a lot and the stress will be much more. After that, it's very important to communicate with your team members. To improve the quality, it's not about you, it's about how you're gonna deliver, what your goals as an institution, what the goal of this, how to prepare our patients, how to prepare our schedule, how to make everything comfortable the best way for our patient. Apart from the clinical work, I'm dedicating a very large part from my life for education. We are working with the Advanced Implant Program. We have a lot of young dentists who are aiming to learn implantology from basic to advanced. Regarding Megamind, from where did I know about Megamind? For me, it's a brilliant idea. So you are connecting young implantologists to share their own cases together. It's not only about selling implants, it's about improving the quality of not only dentists but also speakers. So Megamind, they are creating a future speakers. So the idea was brilliant. Why did I apply for Megamind? I found that it's a great opportunity to network with.
I am Professor Pongsettakul. I am the Dean of the Faculty of Dentistry, 𝐀𝐒𝐈𝐀 University, Bangkok, Thailand. My specialty is oral and maxillofacial surgery, and my passion is education, research, and inspiring the next generation of dental leaders. To me, MegaMind is not just a competition. It is a place where ideas grow and innovation thrives. I join because I believe in supporting young professionals who dare to think beyond the usual. When I was a student, we didn't have something like MegaMind. Global platforms were rare, and opportunities to share ideas internationally were limited. That's why I value this so much. It offers the kind of chance I wish I had. For the next generation, MegaMind is a gateway to connect with peers, to learn from mentors, and to share their vision with the world. It is a chance to grow, share, and truly make an impact. The real strength of MegaMind is that it combines competition with collaboration. It's not about the winning. It is about learning, sharing, and building a community of innovators. I am looking for finalists who show skill, creativity, and a sense of responsibility. Ideas that are not only innovative, but also have the power to help people in real life. Believe in your ideas, stay curious, be bold, and remember the ultimate goal is to make a real difference in patient care and in our profession. Unlock your potential, test your mind, MegaMind.
My name is Emilio Arguello. I am a periodontist. I'm originally from Mexico City. I finished my residency at Tufts University. I spent about 10 years of my life doing research, intense research, so I spent a lot of time studying that bacteria. And when I finished my program, I got invited to become part of the faculty at Harvard University. Now it's almost 20 years since I've been teaching there. In the early stages of my career, I joined the corporate industry, which is one of the largest DSOs in the United States today. Soon after that, I moved to Denver, Colorado, and that's where I practice today. And I joined a private practice. My time had been divided ever since between the corporate world, the academic world, and the private practice world.
Welcome to the MegaMind 2026, Season 4, The Road to Toronto.
MegaMind is a very good project, and I'm honored to be invited as part of that team because that gives the clinicians, especially the younger clinicians, the ability to foster an unbiased approach and knowledge, and not to become necessarily attached to a product or a system. And also another thing that I praise a lot for the project of MegaMind is that they have paid a special attention to the people that judge are not necessarily affiliated 100% to a company and freely judge the cases that are coming through without that attachment to the industry. What am I looking for in that competitive environment? The most important thing is how were you able to serve your patient in the best possible way? Your train of thought help that person's life and improve that person's life. It's also important to think outside the box. If you are able to deliver the correct treatment to your patient, along with an environment that you were able to come around the problem by the open-mindedness of thinking of a potential solution, that makes the case even more interesting.
Didi?
It's okay.
My name is Dr. Beatrice Lang. I'm a practicing prosthodontist.
All right, so Maureen, how's the gum on the, it's healed up, right?
I've been in private practice since 2005. My journey starts with going to dental school here at the University of Toronto. When I graduated, I realized that I was not comfortable practicing yet. So I moved to the States and I did a year of hospital residency at Boston Medical. The 3 years when I was in prosthodontics studying, that's when I realized that what I learned in dental school was not adequate. It was just a lot, there were a lot of missing links. I've always wanted to be able to help people to connect those missing links that were always there. So I got the position to teach back at the same dental school that I went to. So now I've been teaching for the last 6-7 years.
Megamind is a global stage for aspiring dentists to compete for a chance to become the next generation of leaders in implant education.
Megamind Global.
This concludes the Megamind Asia Continental Round. We hope today's excellent presentations will also inspire and benefit your daily patient care. The next Continental Round will be the China Round, taking place on February the 10th at 6:30 p.m. at EST Eastern Time Zone. We look forward to your continued interest and participation. And thank you very much, and I will see you in the next Continental Round, and I look forward to meeting you in Toronto in June 2026. Unlock your potential, test your mind. Megamind.